Hello, NephU community. I want to welcome you to today's podcast on the future of healthcare beyond 2020. I am Sean George, Medical Science Liaison with Otsuka Medical Affairs, and I am joined today by Dr. Ben Cowley, who is the Section Chief of Nephrology at the University of Oklahoma Health Science Center. We are so happy to have you on today to discuss this topic on the future of healthcare beyond 2020. Welcome, Dr. Cowley.
Glad to join you, Sean.
So, Dr. Cowley, obviously we are living in unprecedented times, and every member of the healthcare team, especially physicians like yourself, have been forced to make adjustments in the way you practice. Can you start off by talking a little bit about how your practice has changed over the past 6 months?
I should probably preface my comments by saying that Oklahoma hasn't been anywhere near as badly affected as other parts of the country. And so my thoughts and wishes go out to my colleagues who are in more heavily affected locales. We still do have, some degree of COVID, and as in other places, as we have reopened socially, and for example, with schools, we're seeing the expected resurgence of COVID. It's not overwhelming, but it's kind of steady at this point. I think as a lot of other practitioners have experienced during the initial phases of the pandemic, clinic pretty much shut down, in-person visits ceased, and we did shift to virtual visits. And I think some practitioners, did more volume of that than others. I think, different people have different comfort levels. And then I think different patients have different needs. I mean, some people can simply skip a visit and do just fine, whereas, I think some people need to sort of keep in touch. As things sort of dissipated transiently, unfortunately, the clinic has opened up, and there's now a mix of in-person and virtual visits. I'm a nephrologist, obviously, and so COVID also affected our outpatient dialysis patients as well as the practitioners. I think there was a temporary transition to virtual visits, which I think for some practitioners has persisted, but I think many of us have transitioned back to in-person visits. The dialysis facilities, have been pretty much on top of PPE and social distancing and monitoring everybody. Everybody who comes into the unit gets their temperature checked, and everybody's wearing a mask. There has been some COVID in the dialysis facilities. To my knowledge, it's not large numbers. Interesting, many of those patients, though they have, significant health issues, are remarkably asymptomatic. And so in the inpatient setting, I think we, as a lot of other practitioners, have experienced that inpatient consult numbers are somewhat less than in the past, not dramatically so. And obviously, some of the consults that we weren't seeing in the past have been replaced by COVID patients. And so, though I think our inpatient consult numbers are down somewhat, it's not dramatic. Yeah. And so I think every aspect of the enterprise has been affected. For a period of time, the hospital was canceling elective procedures, that I think most hospitals were. Elective procedures have now been restarted. I'm in an academic institution, and so the academic side of things has been probably more dramatically affected. The office staff are home. In fact, they were home exclusively for quite a few weeks, if not a month, maybe 2 months. We've got a relatively small office staff. There are 3 individuals that work in our office. One's north of 70, and she's still staying exclusively at home. The younger individuals who work in the office are coming into the office 1/2 day a week. So the administrative office and the administrative building in which my office resides is pretty much a ghost town. The teaching conferences has switched exclusively to virtual. So, it's kind of what you would expect. You know, the idea that we need to be, doing the things to prevent transmission of the virus. Everybody in the facility is wearing a mask except when I'm in my office, which I'm in my office now. So it's okay to not wear a mask when you're in an isolated office. But outside the office, everybody's wearing a mask. People are socially distancing to the extent that they can. It's what you'd expect from, the recommendations of health professionals.
It's really amazing how, even though nobody was really ready for a pandemic, that the transition to telemedicine and all that was fairly seamless. It worked out. It seemed like it was a lot more painless as could have been imagined. But I wanted to ask you, how was that transition for you? Was it difficult?
I think, and it probably varies from practitioner to practitioner. I mean, those of us who were reasonably computer facile didn't find it a terribly difficult transition. I think one of the things that I continue to find challenging is whether or not the patient's internet connection is sufficient to support, a virtual visit. I mean, I think I live in a state where there are significant rural areas, and so we've all heard about, limited broadband access in, a variety of, locales, but particularly in rural locales. And so it's not uncommon that I'll, be in a virtual visit with a patient, or attempting to make a virtual visit and they can't connect, or we'll be in a virtual visit and they'll lose their connection. And so that's sort of a minor irritant. Probably half the time what I'll do is I'll just pick up the phone and call them.
Yeah.
I mean, it's sometimes easier. One of the sort of, I wouldn't call it awkward. One of the sort of, and I wouldn't call it silly. I think there are probably legitimate reasons for this, but your ability to bill for a visit depends upon whether you actually see them in a picture.
Sure. Okay.
And I think there's probably some legitimacy to that, but I think it's somewhat overrated. And so, I think I'm guessing most practitioners make an effort to actually, have at least a transient video connection so they can, claim that.
Sure.
I think a telephone's not a bad way of communicating, and it's
Yeah.
a lot more reliable than broadband.
Gotcha. So, as we're kind of looking into the future, how do you think you'll be seeing your patients in the future? Do you think you'll continue to utilize telemedicine where appropriate? Would you like to transition back to complete in-person office visits? How do you see this occurring, even thinking beyond the vaccine?
Yeah, and I think we've talked about this in other venues. I earned the gray in my beard the old-fashioned way. I'm old enough to remember that when we did home dialysis visits, every 3 months or so, if someone was doing well. I don't think there's a good medical reason why someone who's stable on home dialysis needs to come see you every month.
Right.
It's quite frankly a financial issue. And so I think whether or not, and personally, I think home dialysis is probably one of the more appropriate ways in which virtual visits could be of utility. Once again, I live in a state where there are significant rural areas, and so some of our home dialysis patients come a significant distance to come see us. And so I think if they're doing well medically, I think it'd be perfectly fine if there were a physical visit every 3 months and we did a video chat in between. I think whether or not that will persist after a vaccine is going to be purely a function of financial considerations.
Yeah.
If third-party payers, particularly Medicare, continue to reimburse for virtual care, then I think that'll probably persist. If they don't, it'll stop.
Yeah. What was the biggest?
I do think there are probably other venues in which that's appropriate. I think especially if a patient dialyzes in a physical dialysis center, and that center is, some distance from where your office is, that type of virtual visit would be perfectly acceptable. Once again, it's going to be a function of whether third party payers continue to reimburse for that.
Yeah.
Some clinic patients, I think, could probably be, adequately taken care of from a medical standpoint, with a virtual visit and less frequent physical visits. I have to admit, I find physical visits somewhat more appealing because they're
Sure.
somewhat more engaging, and
Yeah.
maybe that's the dinosaur in me. Maybe millennials don't make that distinction, but I find interacting with a person who's sitting next to me to be somewhat more engaging than interacting with someone on a video monitor.
Yeah. I mean, I think just having that personal interaction, also being having the ability to do a physical exam, is huge. You don't get that over,
That's
telemedicine.
it's important, but I think it's more important for some patients than for others.
Sure.
I think a good history and review of appropriate lab tells you a lot.
Yeah.
I don't want to discount the importance of a physical exam, but I think it's more important for some patients than for others.
Yeah. um, you know, Telemedicine's been around for a long time, right? This isn't really new technology, but it took something like this to happen for it to become more solid when you talk about being able to bill for it and those kind of things. Because you probably know that there was pilots back in the day that were done by corporations that allowed us to go in and actually do these telemedicine visits, but we didn't know if we could actually bill for it or not, right? So that's changed with all this.
Yeah, I think the other thing is that, the technology has matured to the point where the infrastructure necessary to do it is significantly less. When people were doing pilots of, telemedicine, in years past, they weren't doing it on an iPad.
No,
They they
right,
had they had fairly sophisticated electronic infrastructure. Now you can do it from your iPhone. I happen to be using a desktop computer just because it's easier for me since I'm sitting in my office. But, the technology, assuming you've got an adequate, broadband connection, is insignificant. I mean,
right.
the electronic infrastructure is insignificant because the technology has matured. And so it's kind of a perfect storm, where the technology's ready for people to make that transition fairly easily.
Yep, absolutely. That it kind of brings me to my next question. So what do you think will be the main driver for the future of healthcare?
I mean, I'd like to be glowing and, pie in the sky, but it's all going to be about money. I mean, I hate to be cynical about it, but, money talks, and med schools have to support their budget, and physician practices have to support their office staff, and everybody's got to, put food on the table and pay their, school debt. I mean, it's like I say, I don't want to sound cynical, but third-party reimbursement practices drive healthcare in the United States. I mean, if we lived in Canada, or we lived in Europe, or we lived in another country where there was universal health care, and, how reimbursement occurred was completely different, I think that will be that it would be interesting to see how that transition occurs, because I think in other countries, the driving forces are going to be different than they will be in the United States. I think in some ways, I think comparing how those, other countries, how their healthcare systems move forward after the pandemic compared to how the United States does, may be an interesting contrast.
Yeah. So that being said, so what is your biggest concern for the future of healthcare?
And I have a sort of I wouldn't say unique, but sort of a perspective that's somewhat specific to my specialty, and it has to do with future practitioners.
Okay.
And I do think that's probably not unique to nephrology. I think adequate practitioners to take care of an increasing number of patients in need is going to be a challenge, but I think it's going to be a unique challenge for nephrology for a variety of reasons that have been discussed ad nauseum. Nephrology has become a particularly unpopular specialty among young people. And so the number of young people who are entering nephrology practice, or at least entering nephrology training, has dwindled and has been quite limited for probably 5 or 6 years now. And so my, concern for the future of nephrology is going to be adequate, well-qualified, well-trained practitioners. As I say, I think there's probably some of that, for medicine in general. But I think in nephrology, I think it's going to be a critical need.
What's some things that can be done to change that? Or is there anything that can be done to change that?
Well, as I say, this has been discussed ad nauseum by national organizations who, have many, people that are much smarter than I am, probably more informed than I am about all the problems associated with attracting people to nephrology. But the word on the street, quite simply, is that young people they think that nephrologists work too hard and don't get paid enough. And I think if you compare starting salaries for nephrology compared to other subspecialties like cardiology, GI, or pulmonary critical care, there's some truth to that. But 5 years later, I don't know any starving nephrologists. I do think some of the concern in that regard is driven by the unfortunate fact that many young people now come out of med school and out of training with heavy school debt. And so, those kind of decisions weigh more heavily than they might have in the past. I hate to make it sound like it's all about money, but that's a big part of it. I do think that there may be some things that we can do to make nephrology practice perhaps less burdensome, at least in the eyes of the young people.
Mm-hmm.
Some of that will probably be a function of hiring alternative practitioners, nurse practitioners, physician's assistants, things of that nature. And I do think because of the relative dearth of nephrologists, an increasing amount of nephrology care is probably going to be provided by advanced practice professionals such as nurse practitioners and PAs.
All right. Well, I appreciate your answer to that. Dr. Cowley, I want to thank you for joining us today as we covered the topic of the future of healthcare beyond 2020. NephU community, I want to thank you for tuning in, and we hope you enjoyed the discussion. We will see you next time here on NephU.